Good morning, everyone. My name is Cindy Hopkins. I'm part of the Delaware Stroke Initiative Planning Committee. It's my pleasure today to introduce to you our next speaker. We have Jennifer Klinedinst. She has a Bachelor's of Science in Nursing from the University of Pennsylvania, Indiana University of Pennsylvania, Master's of Public Health from Boston University, Master's of Science in Nursing from Thomas Jefferson University, PhD of Nursing, Emory University, and she's currently an assistant professor of nursing at the University of Maryland. She also is a fellow in the American Heart Association and is currently doing research on depression and fatigue after stroke. Please join me in welcoming Dr. Klinedinst.
Thank you. My husband finally told me I had to stop going to school and get a real job, so I've finally done that. I have no conflict of interest to disclose to you today. And I'm going to talk to you today about symptoms of fatigue and depression after stroke. And I do have some specific objectives that I'm going to make sure I cover. I'm going to define both depression and fatigue after a stroke today so that we're all clear what we're talking about. I'm going to talk about the prevalence, how often these symptoms occur, the impact of post-stroke depression and fatigue, and identify the current theories and causes of fatigue and depression after a stroke. I'm also going to talk to you about assessment. I'm going to give you some tips about different assessment tools and which ones are valid and have been validated in stroke, and talk about some treatment strategies for both of these symptoms. So let's start by talking about depression. And before I start talking about depression, post-stroke depression, let's figure out what depression is in and of itself. In the past couple of years, the DSM has sort of not really redefined, but major depressive disorder has been defined as having at least 5 or more symptoms during a 2-week period. They have to happen for most of the days during that 2-week period, and at least one of those symptoms must be a depressed mood or anhedonia. This is the loss of pleasure in things that were normally pleasurable. And depression can be present before having a stroke, and it's actually a risk factor for having a stroke. When they redid the DSM, they created some new categories, and one of them is now the depressive disorder due to another medical condition, and this is where post-stroke depression sort of falls under at this point. And you have to have met 2 criterion for this. The first one is it's a prominent and persistent period of depressed mood or markedly diminished interest and pleasure in all or most activities that predominates the clinical picture. And the second criterion is that it's thought to be related to the other medical condition, and this is very common in stroke, as we'll see in a minute. So approximately a third of stroke survivors suffer from depression. Literally just a few weeks ago, there was a large study, a very large study of depression and stroke that was done in Holland, just came out in JAMA, I believe it was, and showed that number may be slightly lower. It might be more like 18 to 20%, but commonly we think of it, it's about a third, and that's what it's been up until very recently. So it's post-stroke depression is associated with increased mortality, cognitive impairments, decreased quality of life, inhibition and participation in physical therapy, so it has like direct outcomes to post-stroke morbidity. And it's a substantial burden to the primary caregiver of the stroke survivor. Not only does it have all these detrimental effects to the stroke survivor and their family members, but it's also really costly. It increases hospital length of stay, it increases the use of other healthcare resources, and decreases the odds of returning to work after a stroke. So when does this occur? It actually happens kind of in 2 phases. Depression can happen very acutely, actually within the first day of having the stroke, and oftentimes that does resolve within about a year. It can also happen in the weeks or months following a stroke, and that tends to last a little bit longer. But on average, depression lasts about 9 to 11 months, but for some people it continues for many years. So we've been trying to figure out for a very long time why it is that stroke survivors have so much more depression than the normal population, which gets it at rates of about 3 to 5%. The early hypotheses, actually, I take that back. That's older. I study older adults too. They're 3 to 5%. Normal population is about 10 to 13. So early hypotheses were, we start with the low-hanging fruit. Maybe it has something to do with the location of their lesion or the volume of the stroke lesion. And there has been some evidence for, in acute stroke, when they have depression, that it has something to do with being in the left frontal lobe. But that's not the case when they develop the depressive symptoms a little bit later. And it has not been associated, although we've looked a whole lot, not associated at all with the size of the lesion volume. Well, then we went to the depression literature and began to look at things like, well, maybe it has to do with the amine theory, which is the current running theory for major depressive disorder just in the general population. And it has something to do with maybe serotonin or dopamine or norepinephrine. And we still are we have not debunked this hypothesis in that we know that SSRIs and other antidepressants are somewhat effective in post-stroke depression, and I'll talk to you a little bit more about that when we talk about treatment. But unfortunately, they're not fully effective, so that doesn't fully explain what's going on in stroke. So some of the newer hypotheses that people have started looking at are things like neurotrophin signaling. For example, brain-derived neurotrophic factor has some associations with depression and post-stroke depression. Activation of the hypothalamic pituitary adrenal axis, looking at genomic signatures like Dr. Wozniak talked about this morning, not just in the development of stroke, but also in some of the things that happen after the stroke occurs. There is a theory out there by a large group of folks who've been looking at depression for a long time. And the theory is that the inflammation that happens as part of the stroke does something and has something to do with who gets depression and who doesn't. And then I had to throw the bioenergetics piece here because that's where my research comes in. I've expanded on the inflammatory theory, and I have my own theory about not only is it the inflammation, but that the inflammation affects mitochondrial function. And mitochondria are sort of the powerhouse of the cells. They make cellular energy, and so if you're not making good enough cellular energy, you're going to feel fatigued and depressed. And there is some basis for that hypothesis, some support of that in the literature, not necessarily in post-stroke depression, but in major depressive disorder and other related disease processes. More to come on that, hopefully in a couple of years. Okay, so as a clinician, you're going to want to know, how do I assess for depression in stroke survivors, and what are the current guidelines? And actually, they're not as great as I wish they were. There's recent guidelines that came out from the American Heart Association, as was mentioned in my introduction. I'm a fellow in the American Heart Association. I have a real fondness for that organization. I think they're excellent. And their depression piece comes within their stroke rehab guidelines, but what they'll tell you in those guidelines is that post-stroke depression is really common and we should be assessing for it, but then they refer you to the palliative care and end-of-life in stroke statement for how to go about doing that. And those guidelines are sort of nonspecific as well. They tell you it's important, we should be screening, but they're not specific about who should be screening or using what tool or when, and just that it should be done. A little bit clearer, sometimes other countries do things differently than us, and so the UK has some guidelines from their National Clinical Guidelines Center, and they're not super specific either, but they do recognize that post-stroke depression is a common problem, that it's an important problem, and they recommend screening all patients, but refer to treating patients with only in the presence of the chronic, in their they have a similar diagnosis as the DSM within the chronic physical condition. And again, they sort of refer you down the line to more guidelines, and they just recommend screening at least at all outpatient visits. So they've got something specific in there. The Canadian best practice recommendations are the most specific. They take post-stroke depression quite seriously, and they say that all stroke patients should be considered at high risk for depression, and they recommend screening at every transition point. So they recommend screening in the acute setting and any time that patient transfers to a different setting, or every few days if they spend like a a long period of time in rehab, like every week in rehab, they want a screening. So they say at first assessment, all transition points, this includes the acute care admission, discharge, rehab admission, periodically through rehab, at discharge from rehab, and at every stroke follow-up visit there on out. They also recommend that you should be screening with validated screening tools, and they don't make specific decisions about which ones you should use, just that they recommend validating screening tools, and I'm going to talk about those more specifically in just a minute. They do say that primary care practitioners, healthcare providers across the continuum, including this, ancillary and support staff, nursing, physical therapy, occupational therapy, you're all responsible for screening for post-stroke depression. So it doesn't just fall on the docs. And that once a patient has been screened, that they need referral to a mental health practitioner. Okay, so some of that is screen early and screen often. Again, everybody is responsible for screening. Even the American Heart Association supports that, and the screening tools have been validated for use with multiple disciplines. And then the other important thing is referral. So once you've screened a stroke patient and they screen high for depression, then you need to know who to refer them to. So I would recommend that you have partnerships or collaborations with mental health practitioners, so that if you have a patient who has a lot of depression, then you can refer them onto that practitioner if they don't have somebody that they already see. All right, so let's spend a few minutes talking about some of the depression screening tools that have been validated, and I'm going to talk about maybe one or two that are not validated, but I think actually the depression ones have all been validated in stroke. And I'm going to start out with the PHQ-9, although I think actually I'm going to switch that. I'm going to start out with the PHQ-2. So Patient Health Questionnaire 2-item is a 2-item screening. It is only for screening, so the sensitivity and specificity are not super high, but it has some advantages in that it's ultra brief. It asks only 2 questions, and these are about those 2 important symptoms in the diagnosis of depression. Do you feel sad, blue, or depressed, or have you lost pleasure in things that were previously pleasurable? That anhedonia piece. The advantage of using this is you can quickly sort of rule out, if they say no to both of those questions, then you can rule out quickly who maybe doesn't need further follow-up for depression. But if either of those 2 questions are sort of on the positive side, then you should screen further with another tool. And then I'm going to move back up to the PHQ-9. So the PHQ-9 is a 9-item scale. The answers, and it's 9 questions that are on the Likert scale. They do include those 2 questions. And the nice thing about the PHQ-9 is that it was designed to be able to detect not only depression itself, but also changes in symptoms over time, and it's been validated to be able to do that. So if you start treatment with somebody, you can follow them over time and make sure that treatment is working. I think my mic sometimes goes off. Okay. The disadvantage is it does have a number of somatic symptoms, and there's a number of symptoms, especially the somatic symptoms, that sometimes get confused with just symptoms related to stroke. So, for example, if there's questions about appetite, and the real issue is that you've got a stroke survivor with dysphagia, and they're telling you that they're not eating very much, that gets a little bit confused. So that's a common downside to many of the screening tools. The other thing I want to point out about the PHQ-9 is that one of the 9 items assesses for suicide. And I'll talk in a minute about what you do about that. But there's a lot of clinicians who are uncomfortable assessing for suicide because then you have to know what to do when somebody says they're suicidal. And I'm going to give you some tools so that you'll know what to do in that case. Another commonly used, before the PHQ-9 came out, because it's relatively new, it came out within the last 10 years, and a commonly used tool before that was the Center for Epidemiologic Studies Depression Scale, and this is 20 items, and it has been validated with stroke, and it has a high positive predictive value. That means it will figure out who has depression and who doesn't. And so it's got good clinical utility for screening. It's 20 items, so it takes a little bit longer to administer than the 9-item PHQ-9, but it still does not take all that long. And the disadvantage of this one, though, is that it has quite a few, and that's been quite a few somatic symptoms, and that's been criticized in the literature for quite a long time for that.